Good morning, everyone. It is 8 o'clock, so we're going to go ahead and get started. We are so excited today for today's ABIN webinar to host our amazing students. First, let me introduce myself for those of you who don't know me. I'm Kim Schuler, and I'm the CEO for the Arkansas Behavioral Health Integration Network. One housekeeping issue, we want to make sure that you know this webinar is being recorded. If you do stay on today's webinar, you're giving us permission to record you, and this will be posted to our website. So with that, we're going to talk about the MSW program that's been happening over the past year. We first want to acknowledge Blue Cross Blue Shield for making this possible. The MSW internship program was able to be started from an endowment program. This endowment program was with the University of Arkansas in Fayetteville and the University of Arkansas in Little Rock. We also want to thank the University of Arkansas at Fayetteville and the University of Arkansas at Little Rock for the opportunity to work with the students this past year. And we have Caitlin Johnson on, and she has been my colleague and co-facilitator of this program and has provided unbelievable support for the students this past year. We also have our fantastic students on, and you're going to see them in a minute. They're going to be introducing themselves, but just wanted to quickly acknowledge and thank them. We have Kat Roberts on, Avis Pfeiffer, Mike Stocker, Amy Perez, Lizeth Guadalupe, and Patricia Rodriguez. We want to acknowledge you all for being pioneers in this project and in this work. All right, so we'll tell you a little bit about how this project got started and some of the things that we did. So one of the things that we did is we really met with the programs and talked about what are some of the needs. We talked about, well, we're starting a new program and this is a new concept. So how are we going to deliver information? And one of the things we decided is we're going to come up with a boot camp. So we developed a 2-day boot camp that we provided to the students in August. And we had great feedback from the students in both programs. And so I think that that was a huge success. With that information, we also developed a curriculum manual that they could take with them. And then we provided supervision and ongoing support over the course of the year. So I think that that's been an essential piece, and we'll talk a little bit more about that. But what we did is we talked about different behavioral health integration models. Our focus was on PCBH. We talked about how to do contextual interviewing, what referrals were going to look like, how to do warm handoffs, working as part of a care team. We had Dr. Gibson on, and she did some psychopharmacology training. We looked at how do we do brief interventions. We looked at short, brief models. We talked about behavioral health integration as really being a longitudinal program. And then we talked about suicide assessment. Here's a photo of us at the end of our boot camp. We have 7 clinics that participated with us that have had students this past year. And these are all second-level graduate students who are going to be graduating in just a couple of weeks. We know they're excited and they've worked really hard. Here we have a photo of one of our students. You could see she's participating as part of the care team. They've had a patient come in and they're reviewing the note together. Another thing that I think has been really helpful is, besides doing our weekly supervision with the students, sometimes it's been every 6 weeks, but maybe once a month, we did a group supervision where we had a didactic learning piece, and then we had a case study that one of the students presented from the clinic, so we could all learn from each other. Okay, and so just wanted to give you a little bit of a snapshot of what the work looked like. And so again, this is seven different primary care clinics, primarily in Central Arkansas, and then we had 2 locations in Northwest Arkansas. So you can see the largest percentage of the patients seen were English speaking, but we did have a percentage of Spanish speaking. And fortunately, we have 3 students who are bilingual. And so that was a fantastic resource. If you look at the breakout for payment, the majority of the patients seen had private insurance. Then we looked at the next highest was Medicare, and then Medicaid. And you could see there's a fairly large uninsured population who probably wouldn't have gotten any type of behavioral health service if we didn't have students on site. Okay, and so this helps us look at what type of referrals happened. We could see that the majority of the referrals were specifically for an identified mental health reason. However, some of them were a referral. I think as the program, as we talked, we realized initially the referrals were based on some type of mental health, strictly a mental health reason. But then as we started talking and really started providing some more education to the clinics, the students started feeling more comfortable. We started seeing an increase of referrals for some of the behavioral health issues, such as insomnia, weight gain, different types of, maybe tobacco cessation, that type of situation. Social determinants of health. One of the things that we realized with the students or with the clinics was there's a huge need for resources for patients. And so students were really instrumental and helpful with identifying and providing some of the resources. Okay, and then I really think that this slide, when we talk about did this work and how do we know it works and our outcomes, this slide, the yellow is the tool score before they had an intervention, and then the green is the score after they had an intervention. One of the things that's really important, and we don't have it noted yet on this slide, is for the PHQ-9 for depression, for patients seen by the students addressing depression, we had a 9.5% decrease according to their PHQ-9 scores in depression after the students' interventions. And for anxiety, we had a 25% decrease when we looked at the GAD-7 results. So that was pretty instrumental, that type of intervention. So I'm so proud of the students, so proud of the work, and so proud to see, one of the things that I think we talk about often is, does behavioral health integration really work? How do we know it works? Are interventions effective? And we've been able to measure. I also want to give you this background information and say this is just a small snapshot It's just the first semester results, and it's based on approximately 200 patient visits. So any questions about those findings? No? All right. Caitlin or any of the students, I don't know if anyone else wants to make a comment or add to that.
No, nothing more than what you already said about this being the first semester. So it's encouraging to see that the clinics were using the students pretty appropriately. You know, a lot of them were using them for already identified mental health needs. But as we discuss, the semesters continued on, we had discussions with the clinical team and the students. It seems that it branched out a little bit as far as the behavioral health needs, the weight management, the diabetes, medication management, that kind of stuff. So we're excited to see what the second semester brings. They're almost there, and we'll be able to provide even more numbers. And we have actual specific percentages on some of the stuff that Kim mentioned. So if anyone wants more in-depth numbers, we're able to provide that. Just for the sake of time, we're keeping it moving, but we're happy to provide that.
Absolutely. Because like we said, we just wanted to give you a quick rundown, a quick update on the types of visits that we've seen and the outcomes. But now I really think the key is to hear from the students and to hear from the providers. And so we have Dr. Lofton on with us today. And Dr. Lofton is one of the clinics that hosted a student this past year. And we want to ask him if he could turn his camera on. And we want to hear some of his experiences. And then we'll move to a panel discussion with the students.
Hey, Kim, you should be able to see and hear me, I hope.
Yes.
Yeah. Yeah, so it's been a really good experience for our clinic. We had Avis with us, and she was with us 3 days a week. And I think initially probably we're a little slow trying to figure out how do we integrate this and make this work. But once we got a kind of a flow down, we would have initially had Avis see a lot of our patients that already had depression or anxiety, or if something came up, help with PHQ-9 and GAD-7s and do counseling. But there's one experience we had where we had a patient that had revealed something to Avis that she hadn't necessarily previously told me, that allowed us to do some intervention and get her placed in what would have been considered a safer environment. So there was a family member that always accompanied this patient to their appointments. And we were able to, Avis was basically able to have a conversation with this family member not in the room. And it opened up some discussions that we were not able to previously have when the family member was always in the room with myself. And so that was a big deal for that family, for that patient, and just showed us the value of being able to have somebody in the room. Maybe when I have about 15 minutes with my patients, and I'm usually taking care of the medical problems. And we do address, I treat a lot of anxiety and depression, and we do the GAD-7 and PHQ-9, but I don't have the time to do counseling and to do brief interventions. And that's where I guess the beauty of this shown through, that by having that, and what is nice is that warm handoff where I was able to go get Avis right after I finished. She was able to come in the room with the patient and take care of a need, versus maybe somebody having to be scheduled to come back, whether or not they'll make it back for those appointments or not. It highlights the need to have, I think probably every family physician could benefit from having a counselor in the room, or not in the room, but in the clinic, so that we can do those immediate handoffs when needed, or being able to just at least a warm introduction so that they can do a brief discussion and schedule a follow-up. But we've started using AVIS for our behavioral health, our weight loss counseling. That's something I hadn't even considered. And, even looking at some of our patients with medication adherence, we're even looking at more and more, what could we use this for? These were not things that I had initially gone into this thinking about. I was just thinking strict depression, anxiety. And so it broadened our view of what the benefits of this could be, and would love to, continue. I want to try to get somebody here full time. Love to see the payers improve reimbursements for these, make it easier, I think, for us, those in my position, to have somebody here full time. And I think the project's a success, at least in my eyes. Love to see it continue.
Dr. Lofton, that is fantastic feedback. Thank you so much for sharing your experience. And we're so grateful, because you hear us, and all the time we're promoting this. But I think really, until you personally have someone at your clinic and you experience and look at all the different ways that you could utilize a behavioral health person in your clinic, I think that speaks for itself. Let me ask you, one of the things that we hear from primary care clinics and different providers is sometimes they're hesitant, thinking that it might affect their flow, it might slow down the provider, it might be a hurdle. Have you found any of that? And how did you address that? And how did you incorporate this into your workflow?
So you cut out for a second. I didn't get all of what you said. Either my internet or I lost a part of that. Would you just repeat that, please?
Sure. So sometimes what we hear is when we're encouraging bringing on a behavioral health person into the clinic and embedding them in the care team, there's some hesitancy that it might slow the clinic down, or it might slow down their workflow. Have you experienced that? And how did you incorporate this into your clinic workflow?
Sure. So I'm a small provider. I have myself and one nurse practitioner. So I would actually say that she improved the workflow. Having AVIS there, it enhanced the workflow, because somebody has to help with the PHQ-9 or GAD-7 or some of the screenings. I saw somebody ask a question about the social determinants of health. So those were things that I have in a limited staff. It was helpful to have AVIS to help take care of some of those for us. And look ahead, kind of do some pre-visit planning, looking for the patients who maybe need an updated GAD-7 or PHQ-9. And so, I would say it's quite opposite. It would actually have streamlined or improved our workflow.
Okay, fantastic. Another question that I just wanted to ask is, we know you're in DeQueen, and that's a rural part of Arkansas. Have you had any difficulty recruiting behavioral health providers in your area? And if you could speak to that.
Yeah, I think recruiting in general in rural Arkansas is difficult, whether it be a medical provider or behavioral health provider. But yeah, it is. And before this, I have not actively recruited somebody, but I do know some area clinics that have had a hard time getting someone. We have to look at it from a standpoint of, are we able to cover, make the ends meet, so to speak. If we hire somebody, we want to make sure we can pay for them. And so from a reimbursement standpoint, that has to be looked at. But we are busy enough now that there's two of us. We do have enough patients that I believe we could at least cover somebody, probably, and we're not hiring a behavioral health provider to make money, but we do want to, make sure we're making their pay. But in general, when you ask people where you moving to, when they say Arkansas, it's not usually DeQueen. It's going to be Little Rock or Fayetteville or Jonesboro. And so, yeah, it's difficult, but I think once people find out that there's good work, there's good opportunity here, that we will find the right person, the right fit, and get somebody here, hopefully full time.
Absolutely. Let me ask, is there, so it sounds like overall this has been a pretty positive experience.
Oh yeah.
It sounds like Avis has really been able to be part of the care team, and it sounds like her the types of visits and patient needs that she's addressed has really grown over the past year. I wondered if you'd be willing to share any advice, suggestions, lessons learned for other primary care practices out there as they're considering would I want to have behavioral health integration in my clinic, and what would be the most useful advice for them?
Yeah, I would say, I know for us, Avis came in at a time when we had also just started our new nurse practitioner, and I've had some transition with staff where we had some people graduate and move on to, one went to nursing school, one graduated from nursing school. So there was some transition, and it made it awkward. I think not awkward, but for workflow, I didn't have a team that was fully integrated into the clinic themselves. So it was a little slow getting started, but I think for another clinic, it's just expanding your horizons on what they can do in your office, and then not think just in that box of depression, anxiety, and thinking through medication adherence, because sometimes those medication adherence can be behavioral or patterns, or I'd never thought of helping with weight loss counseling, because obviously that's a behavior issue. Social determinants of health, that's something that still I saw a question I think Adam had asked. From a rural Arkansas standpoint, that's actually a sticking point, because we can ask all the questions, but what do we do with the answers, because we don't have resources here. And so that's hard, because I know it's a growing need for everybody, but we need, it's hard to ask a question when you say, okay, I've got a problem now, what do I do with it? And I think as a provider, that can be actually frustrating for us. And so, but having somebody on the team that can help with those needs, it definitely would be beneficial. Or, and just another person with another maybe way of thinking, or helping us see things from a different perspective can just add to the team to help take care of our patients, because we try to really take a holistic approach, and that just adds to that.
Absolutely. I think that's such an important point, especially as we're thinking about not just behavioral health needs, but thinking about social determinants of health. And sometimes, especially if we have an intern and they have some time, they might be able to devote more time to brainstorm on how can we get creative and look for some solutions for some resources that are out there. So
yeah, but no, Avis has done a great job. I've been very pleased with the whole process and program, and I think I'd love to. I think every clinic, once they saw what we've benefited from, would want to have this as a part of their clinic.
One thing that I think is important, and I know you've got to run in just a couple of minutes, but wanted to ask, we've been hearing that the volume of referrals has really increased. And so we've heard Avis had a record day where she saw 11 patients in one day. And so that is fantastic. That tells us that you all have truly adopted this type of model and are working as a team. How long, in your opinion, did it take to start seeing an increase in that referral process?
If we were to have another student in the future, I think we kind of have a better idea of how to utilize the student, because at first this is new to us as well. And And I also, we're sometimes creatures of habit, and you get a busy day and you just kind of get in your groove. And some days I would see a patient, and Avis wasn't there every day too. Some days there were patients that were there and thinking, oh, I need, I would send her a message through our medical record system saying, hey, this patient could benefit from seeing you, and she would reach out and try to. And some patients don't want to come back in, but I think there's a part on the clinic side of just remembering initially that, hey, wait, we've got Avis we can use. And so I even if we have a new medicine that comes out, sometimes it's hard to remember, wait, oh, I've got another option here, because you just get in your patterns and your press for time and trying to see patients and not get behind. And so there's still, and I could even say it's probably a work in progress too, trying to figure out how do we fully integrate this and make sure we're fully utilizing all the tools. I'd say, and starting over, if we had to do it again, or if a new, the next round of students for a new clinic, it'd be maybe providing some of those, and maybe if we did, I forgot, but providing some of those ideas of weight loss counseling or medication adherence, some of the things like that I initially didn't think of when I was thinking of having Avis in the office and how to utilize her.
That's a great point. I know you've gotta go quickly because you're teaching anatomy today, but wanted to ask if anybody wanted to come off mute and ask Dr. Lofton a question before he has to leave the call. Or you could type it in the chat. All right. Well, Dr. Lofton, we really appreciate you sharing your experience because, as we've said, it's one thing for us to talk about but it's really important for people to hear directly from you as the primary care physician on what your experience has been like. And with that, we'll now talk to the students and let the students share what their experience has been.
Yeah, and just I'm going to step up with thanks. I'm appreciative of Blue Cross and everybody who made this possible, because it's a need and it's beneficial. And I think the more clinics that hear about this, that the more that they're going to want to be a part of this. So thanks for all y'all did, and Avis did a great job. So give her an A.
Awesome. Well, thank you, Dr. Lofton. We
All
appreciate
right.
that.
Thanks. Bye.
Bye-bye. All right. Well, with that, I'm going to turn it over to Caitlin, and Caitlin's going to facilitate a discussion with our students.
You hear that, Avis? I think it sounds like you're ready to graduate. Good to go. Okay, so like Kim said, we're going to go ahead and let the students talk. We've got some questions ready for them. Some of the questions that were in the chat earlier can be answered by some of the questions we're going to ask the students to share about, but we're also going to have a Q&A section, hopefully, if we're timing everything right, towards the end, where you can ask some questions as well as the audience can ask. We didn't get to it earlier. I'm going to go ahead and have my students introduce themselves and where they're at very quickly. So anyone can start, but I just want the audience to know who we're talking with. So you guys go ahead and come off mute, do that real quick, and we'll get started.
Hi, I am Avis Pfeiffer. I am the one that's in D-Queen with Dr. Lofton.
Hi, my name is Mike Stecker. I'm up at the North Hills Family Medical Clinic here in Little Rock.
Hello, I'm Patricia Rodriguez. I'm at the Mana Clinic in Springdale on West End.
My name is Kat Roberts, and I am in the Family Medicine Residency Clinic in North Little Rock.
My name is Leslie Beard, and I am at the 12th Street, UAMS's 12th Street Clinic in Little Rock.
I'm Lisette Guadalupe, and I'm at the Mana South Clinic in Fayetteville.
As I am at the Southwest Little Rock Clinic today for Arkansas Children's Hospital, and I also help at the General Pediatrics Clinic in the hospital.
Because so you guys can see that we've got a wide variety of placements, right? Some are rural, some are going to be in the more metro area, some are in a low income area of the metro area. So we've got a very interesting build where our students are at. So, okay, we'll go ahead and get started. The first question we wanted to throw at our students was how was your experience integrating into primary care? And, I'll preface it with, you don't usually find one of us. You don't usually find a social worker in primary care. You don't walk in the door thinking you're going to talk to a social worker that day or a behavioral health consultant that day, right? So sometimes there's some bumps in the road. What was your experience integrating into a primary care practice?
I can speak on this a little bit. Working with Arkansas Children's, they do already have a social work staff at their clinics. So my experience was a little different, but it was good integrating in just because my position as a behavioral health consultant was very, in ways different than just the social worker that's working there. We worked together a lot to help patients, but it also gave us more time to work individually with families and even patients alone that needed that support from me as a behavioral health consultant.
I think for me, it was a bit bumpy, but the providers at my clinic were just so excited to have this new program be implemented into their clinic. So they were ready and eager to refer patients to me and to have me there. However, it was like they didn't have any for me to remind them, hey, I'm here. I can do this. I can help you with this patient. But overall, they were just so welcoming and eager to have me there, which made that a little easier.
Yeah, I want to bounce off what Lisette said, having the clinic be really warm and receptive, even though we're all kind of like, I don't know what we're going to do, but we'll figure it out. But the figure it out together piece is really important. And then it made going to my internship 3 days a week a lot more pleasant. And I looked forward to it every day. I was like, oh, I get to go see patients and I get to work with the care team. And that helped a whole lot.
I think for me, I had initially struggled with the structure coming from a mental health clinical background. The structure is different from the integrated approach. And so that's what I found difficult. With support, plenty of support from Caitlin, going back and forth with her, we've been able to this semester, iron it out and be able to, it's really the time to, not necessarily a constraint, but being able to hold those restrictions on the time. Where I was coming from, a clinic that I was able to do 1 hour sessions, going to the brief interventions. And so that was a transition for me, but we've been able to integrate it in a positive way where it's been effective and been able to have a positive impact on the clinic and on the patients as well.
So I guess it's my turn. Coming up to North Hills, they kind of hit the ground running and gave me tons of people to see immediately, and it was a little overwhelming. Like Avis, I come from a more traditional style mental health background. Me personally, it was more inpatient. So I was with people, 12 hours a day, seeing them here and there and doing all that. So that was a little weird trying to adjust to that. But the staff up here were really excited to have me, and they've been very good at kind of integrating me in, even though there were times where I'd have to walk down the hall with, a cup of coffee in my hand and be like, hey, how are you today? It's been 3 hours, hadn't seen anybody. What's going on?
I want to bounce off of Mike and say that coming from the traditional clinical background as well, it was definitely an adjustment, but similar to kind of what everyone has been saying, with the rest of the team being so excited for my presence in the clinic, like meeting that excitement was easy, and also made me feel excited to be part of the team and the clinic. And for me personally, it's just been it's been an adventure, really. And it's been extremely rewarding. And the integration into this setting has been nothing short of just very fruitful and very rewarding.
Go ahead, Leslie.
I want to bounce off of everyone as well. I also have had, like, I went from an inpatient kind of setting, psychiatric hospital, to this setting. So the pace was kind of similar, like the quick pace of everything, but the clinic itself, I just felt so warm, like people were just so excited to have me, and they still are every time. They're like, oh, Leslie's here today, or this would be a great patient for Leslie to see, or I'd walk in the door, oh, we've got to talk to you about this patient. And it's just like Kat said, it just made me very motivated and excited. And I think that's been one of the best things about it, is just having that warm support and people just being so happy that I'm there. And that just made me feel really good.
So I don't know if you guys caught the theme there, but this is a great group of students. I mean, it is not easy to integrate into a primary care setting. They're making it sound easy because of the hard work that they've done, but a lot of times it's like Mike said, it's been 3 hours I've been sitting in my office where, you know, I can see someone. You've definitely seen someone in the last 3 hours that I could see, right? So sometimes you run into that, but it sounds like a common theme is team buy-in, right? And I think Patricia put it well, is I don't know what we're doing, but we're going to do it together, right? And I think that it's often a theme of social work. If there's other social workers on the call, is sometimes we're put in places of we just know we need you. We don't know what we need you for yet, right? And I think that is a common theme in behavioral health integration is you are definitely doing the behavioral intervention, the brief interventions, but there's also some cases of I need some troubleshooting. Can you help with this, right? I think it was a good point that Avis brought up, the integrating into a medical model, right? So you're integrating to the primary care, but then you're also coming from a completely different model. And if your grad school was anything like mine, we were told that the medical model is like, this does not work. This is not great, right? Which, you know, there's a difference of opinions on that. But can you kind of going off of what you guys are saying, how will your time integrating into a medical model influence your practice going on? How do you think this is going to continue to benefit you, or maybe not benefit you in your practice going on as social workers once you graduate?
I think for me, it will be most beneficial as far as the range of diagnosis I was able to experience. If I had just stayed, you know, on the clinical side, as far as, you know, the mental health disorders, I wouldn't have been exposed to the weight management. I wouldn't have been exposed to, I guess if I had stuck with, you know, I want to work with kids, I want to work in the school, I wouldn't be exposed to, you know, recovering addicts and things like that. And so I have learned a great deal from the medical side, just on the premise of behavioral health. It's more than just mental health, it's the actual behaviors. And so that's something that you can learn to implement and coordinate with any person that you're working with. And so overall, I feel like I've learned more in this model than I would have learned in just a basic clinical setting, because they don't have that. You're not talking to people about, their diabetes unless it's directly causing stress or it's triggering something. And so I think this model allowed for me to have a more broad look at the behavioral health, and it's not just mental health, if that makes sense.
Yeah, so for me, I've gained, I guess, a more profound respect for like a PCP clinic and just how insanely busy doctors can get during the day. And I've come to rely on them a lot because there'll be times when I'll be seeing someone and they'll be telling me things and I'm missing a lot of context that I can run over to Dr. Burns or Dr. Chris and be like, what is going on with this person? And so I get a lot more information because they're established. They've been seeing people for years at this point. So I get a much better understanding of it. And that lets me kind of hit the ground running more. So going forward, I'm definitely going to start integrating, at least calling and checking in with the PCP more, because that is just a wealth of knowledge and help. And there will be times when like I would speak with someone for weight management and they'd be telling me things that they can't do stuff. And so, I'll run to Dr. Chris and be like, hey, these are the issues they're having. What can I do with them? And I get help on how to tweak what I'm doing to better suit the client in that moment.
I have to agree with both Mike and Avis. Learning the difference between health behaviors and then how that impacts mental health and then like their other chronic issues is huge. And that's where I feel that this model is beneficial for us to be in the primary care, is to talk about those health behaviors. Likewise, the providers, like I've learned a lot from just having one-on-ones with the doctors, like with Dr. May. He was very helpful in describing the different medications to help patients with anxiety and like the differences between those medications, and consulting with him on a particular patient that maybe I felt there was something else there that they weren't sharing with me. You just kind of get that feeling, and then consulting with Dr. May and him telling me, oh, this is also going on, like, oh, okay, well, that makes a lot more sense. So like to what Mike was saying, that team effort, that collaboration, I feel I will take with me into my future practice.
I really appreciated just the opportunity to get in front of patients who probably would not have otherwise received some type of intervention for whatever they were dealing with. I actually ended up with several referrals related to domestic violence. And then I also had referrals, a couple where the referral was technically anxiety, but what ended up happening that was like the physical result of the anxiety was weight loss into already small people. And they themselves were concerned, and like traditional approaches to weight gain were increasing their anxiety. And they were like, they were just struggling with a traditional medical approach. So adding a behavioral approach to it and kind of just shifting that focus really helped them. And I, terminated with one client in a month, and they were able to not vomit anymore and start gaining weight within a month. And they had been dealing with their anxiety for, at that point, almost a year, and had tried other approaches. And so this intervention changed a lot of things for the client.
Jump in unless anybody else is really wanting to. Okay. Kat, I see that Chris has joined you. Hey, Chris. I don't know if he wants to. Yeah.
He said hello.
Hello. Chris is a CAT supervisor over at her clinic, and he has been phenomenal with her. We appreciate him working with her as well. So, okay, so a couple of things that I took from that. Sounds like team-based care is something that you guys are going to take into your practice going forward. Whether or not it's in behavioral health integration, we hope it is. We hope you decide to stay with this model. But even if you go a more traditional route, maybe do an inpatient or outpatient practice, whatever it is, it sounds like team-based care is at the center of what a lot of you have taken away from this. And I agree. I think that is going to, like Patricia said, increase access. You're going to be able to talk with that person's PCP and collaborate a lot easier than is traditionally done right now, right? And I also heard just a more holistic type of care, right? So even if you aren't in this model and you're going out and working in the community, you're going to know that diabetes is going to affect mood, right? You're going to know that somebody's hypertension is going to affect their mood. And again, with the diabetes, their motivation, right? So you're going to be able to understand some of the medications that come with this, and then some of the diagnoses that Avis is talking about. It's broaden that. I can work on all kinds of stuff. I don't just have to stick to the depression and anxiety. I can do weight management. I could do medication adherence, those types of things, right? So it increases access in those as well. Patricia brought up a good point. The patient that you were just talking about is you concentrated on like weight management and behaviors. And that sounds a little bit, that can sound a little bit different from the typical referrals that you get as a social worker in primary care. There's a big spectrum, right, of what you can get. What are some of the referrals that you have been getting? I mean, what are I know we saw a little bit of the theme of what you've been getting, but what are some of the referrals that you've got a lot of, and maybe some of them were surprising to you?
A lot of a lot of just young people in transition, actually, like transitioning out of high school into college, or from college into the next phase of their life and career. And then a lot of stress management as well, with parents working, running a business, trying to do everything, raise their kids, be good at work, be good at home. And so a lot of stress management, sleep hygiene was the basis of a lot of things. If you don't have sleep, good sleep, it's hard to manage almost any other health issue. So there was a lot of sleep hygiene and kind of routine building with folks as well.
I would say the same as Patricia. Being in a college town, I guess, I did get a lot of young adults transitioning from smaller towns in Arkansas into Fayetteville and into the university. So like that anxiety because of that transition. I also got a lot of grief. So it was a great opportunity to educate myself on the grief process, and at the same time educate others on how grief works. Because what my experience was when I did meet with patients who were coping with grief, they were just focused on that, and they didn't realize in what areas, like in their health, that it was impacting. So just kind of helping them get to realize how it was impacting their other areas of their life, such as sleep. So sleep hygiene was also another referral that I got. Other referrals that I was kind of surprised to see, not really, but it was as a result of other things that I was seeing. So I'm trying to say.
Yeah, I would kind of also say a lot of grief, like probably a third of the people that came into the clinic were for some form of grief. And then there was a lot of very traditional depression and anxiety, to the point where it was kind of weird to me seeing people go to their primary care doctor for the level of depression that they were dealing with, because that would be someone that you would traditionally see in like a behavioral health clinic somewhere. And then there's been a pretty decent amount of people for like drug use and alcohol use. and things like that that I've had to deal with as well.
At my clinic, I see a lot of times my patients really just simply need me to gather resources for them. They have their score low on or 0 on the PHQ-9 and GAD-7, but they they're lacking, like they don't have insurance for themselves or their child. And so sometimes we would take that session and we would, I would help them apply for medical insurance or get them information on housing. And I compiled a whole list of resources here in Little Rock for the food pantries and things like that. So I saw that quite a bit at the clinic that I am at, 12th Street. And then I also saw quite a few patients that were dealing with some suicidal ideation, death ideation. And so I had to do some interventions in that way, which could be a little, intimidating, but Caitlin helped me. She was there to help me, like through text and phone call. And I became where I was in I kind of noticed that the clinic's doctors and stuff were, of course, kind of scared, and it was a little newer for them, but they were just had such ease that they got to talk to someone like me in a situation like that. And that was really a good experience to just recognize, like, there might be, they just felt like, okay, we have someone that's like, that can really help us with this. And so I felt really appreciated in that area.
I was gonna,
Oh, go ahead.
sorry, Caitlin, I was gonna ask Amy. Amy, I don't know if you'd be willing to speak to some of the things that you've been seeing at your clinic and any surprises about the level of severity of things that are coming in to primary care.
Yes, I was just about to mention my experience. Working at the pediatrics clinic, I see a lot of young adults as well as just kids, youth, and a lot of the time I see them for anxiety and depression. Sometimes it could be a stomach ache and the doctor sees everything's fine, but the kid is just really anxious about something, and I get to provide that support and ongoing support too to hopefully lower that anxiety. There's also been I've noticed an increase in suicidal ideations and death ideations in a lot of these patients. So that's been something that I've been able to work with the patients. The social workers there as well, they do the same, but as a behavioral health consultant, I get to actually set up follow-ups and actually meet with them in the primary care clinic and just provide that support and education, psychoeducation for these patients that are struggling with severe depression.
I have so many more questions. We don't get to talk to the students in a big group like this often, maybe every 6 weeks, like we said on there. So I'm excited to hear of collectively all the work that they're doing. Just to make sure we have enough time for questions, I'm going to go ahead and kind of tie us up here. But it sounds like a lot of the work that the students are doing is preventative, right? So things like grief, we know is not really a clinical thing. Grief is a normal human thing to experience, right? We really don't need to make it a clinical thing, but we know if it gets prolonged and it's affecting your sleep and your eating and your exercise and all of that, we know that becomes clinical, right? So a lot of the work that they're doing is preventative to prevent it from getting to that point, which affects other chronic diseases too. So a big theme of what the students do is prevention as well as intervention. So okay, really appreciate you guys sharing your experiences. I know there's a lot more that we can talk about. There are several good questions in the chat that I want you guys to have time to answer. I'm gonna go. Adam had a couple of good questions, so I'm gonna go ahead and ask his most recent one. Is there anything you'd change to help other students make the adjustment into integrated care? Are there things that could be changed to make it go smoother?
I think the one thing that really, really helped me was the mock session that I had with you, Caitlin. It really helped to put things into perspective. Aside from the training that we get, there's nothing better than being able to sit through and actually have that brief intervention session. And so that really helped me to put things in perspective.
I would say it's kind of like trying to do a traditional hour-long session in like half or a quarter of the time. So it's very kind of getting in there, getting all the information you need, coming up with an intervention and doing it right then and there. So that's a skill they really have to work on. For any students coming into this, I would highly recommend just kind of familiarizing yourself with the immediate use of different therapy techniques and models. That way, when you go into it, you kind of have an idea of how you can implement it right then and there.
I think for me, I don't have any clinical background. I have a lot of work background in community work and different types of interventions with individuals and families. But maybe there was not a BHC at the clinic I was at. So I think an opportunity to observe and get some more hands-on observation and practice would have been really helpful.
I think also that a wider range of knowledge with policy, state policy and federal policy would be very beneficial for incoming students, because at the clinic that I've worked at, I've done some work with creating 504 plans, IDEA plans for students at schools, not just secondary or elementary schools, but even at the college level. And so having some background in policy would be beneficial.
And last thing I'd like to add, the students might not like this, but it would have been helpful for me to know a little more about the pharmacology as far as what the clinic uses, not just for the mental health, but also for like diabetes, Ozempic. I hear so much and I'm just like, what is that? Am I supposed to know? And so it was kind of intimidating when I first got on, because I didn't feel like Dr. Loftman expected me to know it, but they were throwing medications at me that I was not familiar with. And so I had to go back and do a lot of studying. So even the pharmacology will be great to know.
I want to speak again and just say that I think that getting students in the setting and just having the experience is really important, because since this model is relatively new, there aren't many standardized brief therapeutic approaches available already. So just having somebody in the setting to further that literature and that research base would also be beneficial for incoming students in the next few decades even.
That's all a great point. Go ahead, Adam. I see you come off mute.
Well, I just wanted to say thanks for the really great responses to that. Arkansas Blue Cross was really proud to partner with you guys on this. I know Rebecca's on, and she headed up this initiative. So I don't know if she wanted to say anything, but really excited about the work that you have done and the future of it too.
Yeah, Adam, you're spot on. We are just so thrilled and thankful for the work that has taken place. It's so inspiring to hear from the students. And I'll tell you, when we were back in 2020 and 2021, when this was just an idea, when Dr. Vic Snyder and I were sitting in a conference room on the phone with Dr. Gibson and Kim, just saying, would this work? Is this something we should approach? We were talking about, will the doctors accept students in, and will this be, something that we can be excited about funding with the Blue and You Foundation? And so to hear a physician say this is needed, and for you students to hear your testimonies, I'm overwhelmed. So thank you.
I know we're close to time. I just wanted to say again, Arkansas Blue Cross Blue Shield, thank you for making this possible. University of Arkansas, Fayetteville and Little Rock, thank you for participating and believing in this model. And students ultimately are gratitude and thanks goes to you, because without you, without your hard work, without your willingness to be the pioneers and trailblazers, this wouldn't be happening in 7 different clinics throughout Arkansas. And so I am so grateful for you all, and know that we are so much further than when we started in August with spreading this across Arkansas in primary care. You guys are amazing. You're going to go out and do wonderful things. And I'm so excited to see the work that you do, and excited for you to share behavioral health experiences. And I also have to say, Caitlin, I am so grateful to you for the work that you've done with the students, and absolutely. And Dr. Gibson, your support and encouragement. And, you know, we've had really a tight infrastructure on this project. So thank you all. It's been a year of hard work, and congratulations on your graduation. Take care.
Congratulations, and thank you all very much. This has been great, and it's good to see behavioral health integration being advanced. And two, you can go home and from your graduation and work knowing that you have really impacted some people, some individuals and some families already, as much as impacted and improved our communities and our healthcare and the system. So we just want to thank you for that. And it's not a loss that you've made a difference in people's lives, and we appreciate you.
Congratulations.
Take care.